This week on the Backtable Podcast.
The key question is the patient still symptomatic? And like the scenario that you're describing, you put it in, it's like a big effusion, it's been tapped before, it's free flowing, but all of a sudden, for whatever reason, now it comes back loculated. The patient comes to the ER and, they've been getting a liter off religiously for 1 week and all of a sudden it's not, and that's an issue. But it's like, well, how symptomatic are you? Like, are we meeting your treatment goals? And that is like the absolute key question.
Hello, everyone, and welcome to the Backtable Podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on backtable.com. Now, a brief message from our sponsor. This discussion is supported by Philips OBL and ASC Solutions Symphony Suite, the industry leader in opening cardiovascular office-based labs and ambulatory surgery centers. With the convenience of a single trusted point of contact, they offer more of what you need to turn your passion into reality, including a full range of high-performing, highly specialized equipment and services, devices, financial options, site planning, guidance on construction partnerships, and more. When it comes to opening an OBL or ASC, Symphony Suite delivers convenience and support as the expert you need, the partner you trust. To learn more, visit philips.com/Symphony Suite. Now, back to the episode. Today I have a great episode with two of my co-hosts, Ali Behetti and Chris Beck. Welcome, guys.
Hey, good to be here.
Thanks, Aaron.
This is unique, right? We haven't had this combo yet.
I've never been on a podcast with Ali.
Yeah.
Oh, you're right. That's so cool. I get to actually see your face in person.
No, it's a big deal for me, not for you.
Wait, Ali, have we done any together?
We've co-hosted a couple together, but never just a you and me podcast, and never just a me, Chris Beck, and Aaron Fritz podcast. I feel like I'm in the presence of celebrities.
Yeah,
That's
right.
not true. Whenever I listen to our feed now, I'm like, oh, it's just Ali's show, really.
No.
Ali's been cranking them out.
And for the better, too.
The real celebrity comes on Monday with Michael Barazza.
Oh, yeah, that's right. That's the diva.
He gets recognized at parties as like, you're the back table guy, right?
Not just at parties, at LSU football games, where what are the chances you run into...
What? No, I don't believe that.
It was at an LSU football game. Somebody came up to him and was like, and he told his wife who was with him, hey, this guy's amazing, or like, this guy's the king.
Are you serious?
Yeah, it was like an old school moment. Like when Mitch gets like, you know what I mean?
The Godfather.
Yeah, the Godfather. Yeah, exactly. Yeah. All right. Yeah. All right. Well, for our audience today, guys, we're going to talk about tunneled, pleural, and peritoneal catheters, mostly for malignant ascites and effusions. We'll be using the terms Aspira and Pleurex kind of interchangeably whenever we have one of these cases come up. Even if it's at a hospital where we use Aspira, it might be written on the board as Pleurex, right? Pleurex chest, or a lot of times people, when they're referring to a peritoneal one, they'll say Aspira for whatever reason, but we know that these catheters are being used for both. I'm going to get into which devices people like from both Chris and Ali here more towards the end. I kind of want to talk more about the device-specific stuff toward the end. First, we're going to talk about indications, contraindications, and then get into like how you guys place these. And the other key thing being patient education and counseling and making sure home health is set up. So first of all, let's just talk about how are these patients presenting in your practice. Ali, let me start with you.
Well, I work at a mostly hospital-based practice. We do have a small OBL too. And most often they present either as inpatients who've required repeat thoras and paras for whatever reasons, usually malignancy. They may be on the train towards hospice, but usually it's people who haven't committed to hospice yet because of insurance reasons. We'll talk about that. And then they get consulted for catheter placement, mainly for dispo reasons and for quality of life reasons. So we have a pretty developed PA service in this practice, and the PAs will evaluate these patients and determine if they're a good candidate. If they have questions, they run it by the attending, and then the PAs are the ones placing the catheters in our practice.
Really? Wow.
Yeah.
That's interesting. So because I guess they're doing a lot of the thoras and paras already, as we know, it's kind of a few extra steps. But we'll get into that in a little bit. But Chris, where are these patients coming from in your practice?
We have an interesting practice in that I have one hospital that I cover, both, like Ali, hospital-based practice at both facilities. And at one place, there's an interventional pulmonologist, and for a majority of these, like he's kind of running that show. And so I rarely see them. Occasionally, like he takes vacation. And so like we'll kind of get these patients, they get plugged into our system. But at our other facility where we are placing the lion's share of these, a majority of referrals are from pulmonology. Sometimes it's oncology, but they almost always come from pulmonology. Like onc refers to pulm. Pulmonologists at this hospital are doing a large majority of the thoracenteses. And so they'll already have had a couple of thoras. And then depending on operator and kind of the patient situation, they'll get plugged in with us. Inpatients and outpatients we see. So like Allie's situation, a lot of times they're on the hospice train and it's a dispo issue. And then a lot of times it's patients who are just requiring frequent thoracentesis that they thought would go away. Or, there's a lot of like ways you can treat malignant effusions. Like they'll get chemotherapy or immunotherapy or whatever. And sometimes that addresses the underlying issue. But ultimately they will get referred to us and then we just kind of plug in them under our system and get going.
For me, similar to Allie, I mean, oncology is actually usually sending these over. Okay, sometimes it'll be pulmonary for the pleural ones, but usually these are patients that they're pretty sick. They're either in hospice or about to be in hospice, and this is a quality of life issue where they don't want to get stuck anymore. And oncology's used to sending them over to us for this reason. I want to talk a little bit about contraindications.
Before we talk about contraindications, I also forgot to say that we're actually placing a fair amount of these for non-malignant effusions.
Okay, that's what I was going to ask about in terms of contraindications, because in training, when I was taught to do them, it was really mostly for malignant effusion, malignant ascites. And I got in practice and I was like, why aren't we doing these for just like ascites, like, portal hypertension ascites, right? And it was one of my partners was like, no, we don't, because there's a risk of infection. And then I kind of researched it and looked into it, but I didn't do a high volume of them in training. So I didn't really learn about them and all the little challenges until I was doing a lot of them in practice. But Allie, do you know much about that? Like what the risk is for infection and why we don't do that?
Yeah, then that's a good question. And that's kind of the same dogma approach that I had in training too. And to be fair, where I trained, the group that did all of the Plurexes, Aspiras, was the body division. So body radiologists are the ones who taught me how to do this. So I think there's just a different threshold of risk for different types of radiologists. And that was really the big thing was we definitely don't place them in people who have a longer lifespan, expected quality of life because of the risk of infection. And I think I remember one attending telling me having a Plerex catheter is 100% chance of eventually getting an infection. It just depends on how long until you get that. So that's why we really only place them in end-of-life cases. But you're right. Now that I'm out in practice, I do. If people are getting repeat thoras or repeat paras, or for example, aren't a TIPS candidate but still have repeat paras, we're placing these kind of regularly. Maybe it's just one of those differences of training at an academic center versus practicing out in the real world and what the day-to-day challenges are. I am curious about the actual true risk of infection, though. I am not certain of those numbers.
Chris, do you know, or have you looked into that at all?
Yeah, I did the lit search before we did the podcast, but it was like, I thought we were focusing for me, the difference between like these tunnel catheters for ascites and like for effusions, they're kind of different animals for me and I treat them very differently, but kind of what I quote my patients, like if you're going to have a patient who's going to live longer than 6 months and for its non-malignant effusion, I think it's anywhere between under 10%, but above 2%. So I usually say like 5%. I know there's a range in these things and that's my best estimate.
But you say you're getting these for non-malignant effusions.
For sure. CHF patients a lot. Sometimes portal hypertension patients. But, again, a lot of those end up funneled into like your TIPS pathway. And sometimes like some autoimmune diseases, chylothorax. CHF is like what kind of jumps to mind. Can you think of some other ones, Allie? I know there are some.
That's interesting that you put them for chylothorax because I would think that those just get mucked up or clogged up real fast with the chyle. I haven't seen that in our practice. Maybe those guys all go to UW and get lymphangiograms or something. But yeah, mostly just old, frail CHF patients who maybe don't want to stay in the hospital for repeat thoras.
And it's, again, quality of life because their heart's not getting better any faster and who knows what their lifespan's going to be. I mean, it's kind of the same with these like end-of-the-road portal hypertension patients, right? They're not doing well, and if they're not a TIPS candidate and there's nothing you can do for the underlying disease, like why not put one in for quality of life?
Yeah, so whenever I think like non-malignant effusions, you think cardiac, hepatic, renal, pancreatitis, autoimmune, and then the chylothorax. I mentioned that one probably a little bit early. I can only think of a couple of times we did that. We're just trying to bridge them until we could get them for like a lymphangiogram. And there was just like the reason I thought about it is this patient's kind of always top of mind. Is like we just could never she had immunotherapy, and so all her lymph nodes were sclerosed, and then like she needed a tertiary referral. Long story short, we were never able to get thoracic duct embolization, and she even went to Penn, but she ended up with a Denver shunt.
I want to talk a little bit about the most important part of this procedure is, I think, counseling the patient, whether it be before or after, whenever the patient's on the table, and it's one of those you peek under and you're like, hey, how's it going? You quickly explain things. But it's also key to find dedicated time to educate them on how to take care of this, having home health come out. Hopefully all that stuff's set up ahead of time. And again, that's what physician extenders oftentimes will take care of. But I'm sometimes at a hospital where I don't have physician extenders and I got to do it all myself. I want to find out from you guys, do you have a process, or is it just kind of depend on what hospital you're at and who you're working with?
All right, so at the 3 big hospitals I work at and the OBL, the PAs do all of them. At the smaller hospitals, actually, if we are setting up an outpatient, we have them seen in our clinic beforehand for the full consult, evaluation, discussion, and to fill out all the paperwork, right, for the insurance stuff. If somebody is an inpatient and we do them at that small hospital, it's unfortunately just a lot like for any other small case that we might do there. So we see them in pre-op. This practice isn't the sort where the doctors go up and round on the floor beforehand and see consults on patients, except in certain situations. But for routine, run-of-the-mill stuff like that, folks come down. Often the nurse will talk them through it, and then we'll talk to them for like 5 minutes, consent them, and then put them on the table. So we don't have a very good system for those inpatients, which is probably the vast majority of the Plerex catheters that we place.
Same, very similar experience in that our program is not very mature or well developed in this. But I'll also say that we are not trying to be the kings of the tunnel catheters for effusions or ascites. You can always make a case that IRs are the best to put it in, sure. But this is a procedure where a lot of physicians can excel in this. We kind of shunt off a lot of that work on the referring docs. Like if pulmonology, palliative care, oncology wants a tunnel catheter for a malignant effusion or malignant ascites, end of care. I mean, we certainly do our due diligence and make sure the patient's been tapped a couple of times. It's an appropriate procedure. It's safe to do. But as far as doing all that paperwork, I'm good luck. You guys can do it. When it's done, let me know. Happy to put the catheter in. That's one of the procedures that we're not trying to have the most developed. It's just a fact of practice. We have limited resources, and that's not where we're putting a lot of our time and energy. But all those things do need to get done. If for some reason a patient fell through the cracks, of course we would do it, and we would do it with rigor. But the reality is we kind of push it off on the referring docs.
Especially since it sounds like you only get pleural catheters as one-offs when this pulmonology guy is not around, right?
A lot of one-offs. Now, there are plenty of patients for some reason. It's just this kind of hodgepodge system. There's some patients who do get referred to us for thoras for whatever reason, and so we are doing the thoras, but a majority of the times the thoras are done by the pulmonologist and the tunnel catheters get referred to us. At that other hospital with the interventional pulmonologist, he does the thoras and he does the Plerex strains. So
that's a sweet setup you got there.
I love that. I mean, when he's relatively new, so I love having him. Don't get me wrong, we have to cover when he's off, but I'll take him taking the thoras off my plate and doing the Plerex, and he's totally into it. Whenever I think about IR guys can be good at this procedure and I see how enthusiastic he is about this stuff,
yeah,
I'm well, I mean, I just can't beat him. I mean, that's just reality. He just knows so much more about effusions than me,
yeah,
and he's so much more into it than me. So that's my best advice for interventional radiologists is find an interventional pulmonologist.
Yeah, because I mean, I do like these procedures and I find them really, satisfying because it is a quality of life thing, and it's miserable for them to keep having to come back, whether they're inpatient or outpatient, to get a repeat thora or para. And so it's nice to have a home solution, right? We've talked about that with peritoneal dialysis, but the follow-up, right? We just don't follow up with them. We don't see them. So it would be nice if pulmonary did more of these. I've never heard of a pulmonologist doing them. It sounds like maybe they're starting to get trained at it.
I mean, at least with our institutions, the newer pulmonologists are more and more procedurally oriented, whether that's EBUS or bronchoscopy-related procedures or chest tubes, thoras, and that kind of thing. I mean, that can vary widely, I'm sure, depending on the doc and the interest, but the newer docs that are coming out seem to be more procedurally oriented. Single-person experience there.
Are you guys checking coags, or is this pretty benign and you're not worried about coags, Chris?
Oh, I check coags. I have to go back to, I'm on record. I'm very much now like defaulted to the SIR app. So I'll look at that. But
same.
Yeah. But I very much check coags beforehand. A lot of these patients can be very coagulopathic. Now, oftentimes it's a risk benefit, right? I'm not necessarily going to balk on it because like a patient's coagulopathic with no chance of correcting that.
Yeah.
And because I think this can be a relatively benign procedure, but certainly it allows me to risk stratify and like have a more informed conversation with the patient about what that might mean for them.
That's interesting.
Are you looking it up right now, Allie?
Yeah, because it says laboratory recommendations, INR less than or equal to 3, platelets greater than or equal to 20K, but INR platelets not routinely recommended. Technically, for the SIR guidelines, we don't have to check coags, but I don't think I would feel comfortable placing one, especially in a very sick patient, without these numbers.
Yeah, I mean, I've never had one be particularly bloody, but I could see where it could be an issue with post-procedure bleeding at the site. I mean, the last thing you want is like a bloody effusion or bloody ascites that then clots up your tube. So yeah, I do think it's important.
At what point do you pull the trigger on, okay, this is too many thoras, let's put in the catheter?
Okay, so I'm kind of a pushover for procedures. So if like a referring doctor is like, this person's had 3 or 4 thoras, can you put a tunneled line in, please? Then I'm like, okay, sure. It's got to be like at least like 3 or 4, 1 or 2, especially with a new presentation of a large pleural effusion. That's not enough for me to put a catheter in and make somebody catheter bound for the foreseeable future. But I'm not a real stickler about, they need to be heading towards hospice or heading towards palliative care before we put one in. That's for the pleural ones. And then for the peritoneal ones, I would say like at least half the time the patients haven't had a complete workup for a TIPS. And that's actually a great place to capture those patients, right? Because then you can just say, okay, well, we'll see them in clinic and we'll talk about if the Pleurax is the right thing for them or if it's a TIPS consult. And then it gives the referrer something that they can hang their hat on, that they know that this problem is going to be addressed, right? But it also doesn't commit you to placing this catheter. What's your algorithm, Chris?
So minimum number 2 and preferably, like you said, 3 or 4. I'm not hard on fast on this either. And, so much of it is like patient specific, like a patient has like a malignant effusion that brought them into the hospital, got tapped, and then recurred like 3 days later. That's like a different deal than something else that's like, oh, we see this patient every 4 weeks for a thora. And so like it's hard to like paint it with a broad brush, but definitely not 1. 2, sometimes if it's like rapidly onset and rapidly accumulating. But 3 and 4 is like, I think, a good number that establish like chronicity, persistence, and that the patient can benefit from like long-term pleural drainage. And one of the important things, like to drill down for some of the audience, is that like I'm not conservative about putting these in, but there's a reason that I want the patient to have enough flow to keep these things open. If they're just getting tapped like every month, like sometimes I worry that there's just not enough pleural fluid in there to be flowing through the catheter, to where it's like in between drainages, it's just going to get gunked or clogged up, gunked being the medical term for it.
Do you ever just put in like non-tunnel chest tubes for those people that are recurring really fast, just to see if they can medically optimize them before you have to place a tunneled catheter?
For sure. That's a scenario that plays out pretty regularly, in that, you're doing a thora and then all of a sudden you're like, oh, well, let's see if like we can get a chest tube in them. And while everyone's getting their ducks in a row to like treat the underlying issue.
I've done it for heart failure, but not for cancer patients. Like when it's cancer and it's just like, we get pressured by oncologists sometimes. And sometimes they come to us right away. They haven't had a thora yet. They've been pan scanned. They've got a huge effusion and they're like, oh, we're going to send this patient home on hospice. Can you just put in the tunnel catheter? And I'm like, can we try just doing a thora first and see if it comes back, right? And then if it comes back in a few days, and we always say, hey, we can place the tunnel catheter as an outpatient. It doesn't have to be done while they're inpatient. And so that's what I always have to, and so it's worth obviously having a discussion, doing what's best for the patient, for their condition, for their home situation. Because a lot of times these docs forget that these patients need home health care to help take care of the catheter. And so it's kind of a case by case. That's why I hate when it just pops up on my schedule and I don't have time to like properly talk to the patient, their family members about what to expect. And when that conversation happens afterwards, sometimes you get those wide eyes. They're like, whoa, wait, what are we doing? And that's where the patient education piece really becomes super important.
To speak to your point, the challenge about talking about tunnel catheters, either with effusions or ascites, is that you see just such a wide range of patients, like at all different stages of their effusions, of their life cycle. And so that's why it's hard to paint it with a broad brush. But I think this is one of those procedures where it's good to slow down. Like if you get a consult on a Tuesday, I don't feel like compelled at all to have that procedure done by Tuesday, and certainly not Wednesday or Thursday. Sometimes it takes time for patients to get there. Sometimes it's just totally more appropriate to like do a thora or a para, live to fight another day, and have that patient be able to process like, this is where your disease is heading. Like I've prepped you that like this effusion's going to come back. Let me prove to you that it's going to come back. And so this is a procedure where I like to pump the brakes a little bit and slow down. Now I get it. There's all kinds of patients where like pumping the brakes is like the difference between spending their last couple of days at home. And so I'm not saying that, but yeah, I think that like the referring docs sometimes get like guns blazing, like get this catheter in so we can get them out of here. When it's like, look, we can always tap this and bring them back as an outpatient. That's always in your back pocket, which is a really, really good tip.
Exactly. All right. Well, let's walk through a standard. Let's start with pleural with you, Chris, since that sounds like what you're doing more of. And then we can do peritoneal. And there's a lot of crossover. So peritoneal doesn't have to be quite as long. But Chris, tell us, like, first of all, patient positioning. I have a way I position these, but let's say it's a right pleural effusion. How do you usually position them on the table to start?
Supine with a roll under the right hip. So I just have them a little bit opened up so I can get access to the mid-axillary line.
Perfect, yeah.
But let me back up even one further. Cath lab, CT, ultrasound, bedside, where do you do it?
Always cath lab for me.
I wish it was always cath. That's my preferred location. The reality is sometimes I just don't have access to the cath lab like I do CAT scan or ultrasound. And so out of those, cath lab's number 1, CT's number 2, ultrasound's number 3. I just don't do them bedside. A roll underneath the left hip. It's important for me to like not have the roll underneath the back. Like I want the roll underneath the hip to open up. I want to have like access to that thorax.
So left, so because we started with the right.
Oh, I'm sorry.
So if it's the right side, you're going to have the roll under the right hip, right? So that it opens up that right.
Yeah, so I can open up their right side. I can see more towards the posterior part of it. Not that I want to stick posteriorly, but you know, if you're sticking with ultrasound, the ultrasound's got to be in a certain position. You have to have enough window. Preferably ipsilateral arm up and above the head. I like that because if you're doing for effusions, open up the intercostal space. I'll pick my spot with either CT or ultrasound, lido, lots of lido, dermatotomy, entry site with like the UE needle or whatever synthesis needle comes in the kit, get my wire in. And then once my wire's in, you kind of just like treat it like a tunnel dialysis catheter and that pick a spot that's like 5 or 6 inches away, or so 5 or 6 centimeters away from the pleural entry site. And I like to try and put it in a position where, to my best guess, it would be easily accessible and comfortable for the patient. So I don't like put it right over a bone. I try and put it over like kind of a loose flabby part of the skin if that exists. And gentle curves, like I don't like any big acute angles. Like I don't go from like, that's hard to explain, but you know, I don't try and like tunnel one way, but I'm sticking the pleural site in another, which I've seen done. So nice gentle curves, like vectors that make sense. Then I bring the catheter or the synthesis entry site. And so now I've got it pulled through. I don't think I use a dilator. I just go straight to the peel away sheath and then pull the peel away sheath. I don't pinch the valve or anything. I just dunk the catheter in, peel away sheath comes out, pull it back just a little bit so that cuff is kind of centered, like maybe it's not like at the skin surface, but it's not so deep where I have to like just dissect 6 centimeters down to like pull it out later. And then tie it off with Ethilon, glue the skin entry site, and that's it.
And you drain right then and there, like whatever's in there?
I drain on the table. One, I want to make sure that the catheter works and then that it's in a good position to drain. If I place it under CT, you know exactly where it is. If you place it under fluoroscopy, you know exactly where it is. If you place it with ultrasound, I mean, it's critical that you got to have good drainage or else like, what are we here for?
Yeah. Well, I forgot one like big contraindication is basically if they just got tapped that day, right? Like,
oh yeah,
if they're empty, then there's nothing to stick. And so that has happened, right? Where they're like, they order a thora and a catheter on the same day and the thora gets done. And then the cath lab's like, what are we doing here? Are we actually going to, it's like, no, now we got to wait 2 or 3 days for it to build up. If it builds up, that's another thing that can be a headache and can happen. A couple of things to add to your technique. That's exactly how I do it, Chris. When I do the tunnel, I think they recommend like 6 to 10 centimeters.
Oh, really?
And it's all,
I I didn't know that.
Yeah, so like I'm usually like 3 inches. Like I measure about 3 inches,
Okay.
and that's about that's about 6 to 10 centimeters, and it depends on the size of the person. And so what I always do is I tunnel along that intercostal space. So like you were saying, like you don't want it to be right over the rib. So I just have it follow between the ribs in that space. And then that way, like you said, it's not right over a bone because that can cause a kinking. And then I like what you said about it being like, and usually that's where the fluid is, right? Because it's dependent, is you're angling your UE into the posterior dependent space so that your wire goes posterior. So then your catheter, as it's going down, goes posterior, so you have a nice smooth angle, right? It's not like an acute angle.
The procedure is easy. Like Ali said, you guys have your PAs do them?
Yeah.
Yeah, so the procedure is straightforward. There's just a couple nuances to it. And one of the nuances I will say is where your skin entry site is and like that kind of trajectory of the needle as you're entering the pleural space. I used to, like when I was doing it with ultrasound in cath lab, kind of just give myself a beautiful picture with ultrasound. So I'm intercostal and then I stick and then I kind of torque the needle up. But really what I've kind of gotten to now is identify where a big pocket of fluid is. I'll actually put the needle a little bit more inferiorly and it's almost like I'm poking their rib. And then I just continue to work that needle cranial and then I pop over that rib. I just think that one, it creates like a nice, like smooth entry site where you don't have like that angle where you're going directly lateral or directly into the pleural fluid. You're angled more up. And I don't like it when the catheter, sometimes like a lot of patients have some intercostal pain. And so I don't know why, but I just feel like the further away I am from the undersurface, like over surface is like okay, undersurface to me is where they get a lot of the pain. Anecdotal.
Well, another reason to check coax, right? I mean, you could potentially injure the intercostal artery and nerve, so that's another good reason to go over.
The place that I've seen people go wrong with pleural is just with the end location of the catheter, right? So if it lands in the fissure near the apex, then you're hosed. See what I did there? You should definitely try and figure that out and get it in the right place before you make your tunnel and everything. For a stretch there at a different job I was at, the pulmonologists were placing them and they were always landing in the apex. And so we just kept having to take those out and replace them. But yeah, that's like the only real place I've seen people mess up bad with the Pleurex catheters, which I think if you're doing it under fluoro, you can avoid that pretty easily.
Hold on. What do you mean? You can't land them in the apex? What do you mean? No, I'm serious. Like I sometimes will land, like mine like kind of track dependently and then like they're on the posterior margin.
Oh, I guess that's okay. But like a lot of times I see them basically just going straight through the fissure and then.
Okay. All right. I was like, oh my God. Like I felt like so silly. I was like, oh no, sometimes mine are pretty high.
No, I didn't mean
okay.
it like that. No, but just basically, right. Like you said, what's the word you used, Chris? You want to watch your angles. What did you say?
Vectors.
Yes.
Well, yeah, going through the fissure, that would be problematic. The other question is, because pleural space is smaller than peritoneal space, I always cut mine because they're excessively long, right? So for a pleural, I cut, I don't know, maybe a few inches off. I mean, they're really long. So like, I might even cut it half to the size because you don't need that much length. And as long as it's positioned well, it actually might help prevent it being malpositioned by going somewhere it shouldn't by being a little bit shorter. What do you guys think about that?
One thing I learned very recently, like I think within the past week, is that there's a pleural kit and a peritoneal kit, but a lot of places will only stock one of them for prices. So I'm not sure if I've been using the pleural kit because it seems like it's shorter and I don't have to do that. But yeah, if I'm using the peritoneal kit, I'll definitely cut it. And one is cheaper than the other two. I'm not sure which one.
Probably the peritoneal, and that's why that's all we have is the peritoneal one.
Yeah.
Okay, moving on. Let's talk peritoneal. Ali, walk us through your approach.
Well, I just have them supine. I'm right-handed, so I usually just out of ease just place it on the left side actually, but it doesn't matter. I usually take a look and see kind of where the biggest pocket of fluid is too. I think I learned in training that it has to be at least 5 centimeters worth of pocket to place it, but I don't think that's a hard and fast rule. Try to place it away from any places that have peritoneal carcinomatosis because the catheter might get gunked up, as we like to say, in that stuff and not work so well. And then the IFU guidelines actually say that the insertion site is usually lateral to midline, 6 to 10 centimeters below the costal margin and above the patient's belt line. Now, when I do peritoneal dialysis catheters, I have patients show me where their belt line is, but I haven't really made that a practice for when I do tunneled peritoneal catheters. but maybe I should. No, don't do that. Chris says don't do that. It's a waste of time. It probably is a waste of time.
I think whatever you're doing is just fine.
Yeah, and then I just mark where the catheter exit site is. Again, I use the smoothest vector. Man, I'm totally going to steal that. I love that.
I feel embarrassed for saying it now.
Which is usually 5 to 8 centimeters superior medial to the guide wire insertion site so that the patients will be able to manipulate it themselves if they need to. Drape and prep, just numb up the access site, do the access. I usually just do access with like a UE needle. And sometimes I use the valved UE needle just so it doesn't spray everywhere. Maybe because I'm a millennial and I don't use Chiba needles for anything. And then, except for crossing long segment CTOs, that's it.
Right.
And then put the guide wire through it. Do you guys use the kit guide wire or do you like to change over to an Amplatz wire or stiff glide?
I like Amplatz for everything. Kid wires suck. Universally suck. Wouldn't you say? I mean,
yeah. What is with that? Why can't people like make good kit wires? Thank you.
Chris is rolling his eyes.
No, I mean, I will sometimes use the kit wire, but I prefer to have like a longer wire. I use whatever's in our cath lab pack, which is just like a Benson. So I don't actually, it's very infrequent that I'll actually get an Amplatz or anything.
Oh.
Yeah, like, so it's not like super stiff wire.
I like to use an Amplatz too, and then put an Amplatz through it, take my introducer out, make sure I make my tunnel, do the tunnel tract, pull it through, do the peel away. One thing I learned when I was first starting these was I always tried to make a really, really small incision putting my peel away in, right? And that makes it really tough to do. So I think one of the most important things that an early mentor taught me was make that incision bigger than you think you need it to be. You basically have to have like 2 catheters worth through to get that through, right? So make that incision a little bigger and then push it in, make sure it's working and hook it up. I think like all in all, the procedure takes 15 minutes to do start to finish, right? Not a difficult procedure, but it is a little bit more nuanced than a tunnel dialysis catheter placement, for example, in the neck or in the groin, because you have carte blanche with the abdomen, right? Like you can start anywhere, you can have your tunnel go anywhere. And that kind of planning and knowing where to go, I think, is the most important part of the procedure.
Do you use the, in the Plerex kit, it's like this little orange stiffener that goes into the catheter? Do you use that?
Definitely. Like, why not? It's there and it makes it stiffer and easier to push through the peel away. Might as well. Have you seen any downsides to using it?
I don't have any other than that sometimes, I mean, you just have to put it in. It's one more thing, I guess. Some of my partners don't, but the reason I like it really is just sometimes like you stick in an abdomen or like a really tight effusion, it's like a gusher. And so the quicker you can get that catheter in, like the less it's going pouring out over you. But I'm with you. It's also like gives you a little bit stiffer catheter to dunk.
Yeah, and I think it tends to go more freely, like somewhere where you want it to go in the abdomen, especially, right? Whereas it's so frustrating when you place one in the abdomen and it just kind of sticks to the side and it's like up against the abdominal wall and it didn't really go dependent. Sometimes in that case, I'll take my Amplatz and try and reposition it. That's where I think the stiffener really helps. I wanted to talk about this anyway. There was a post on the SIR forum by Gabriel Werder where he was having issues and he was trying to decide on the best device. And I was thinking about it, I'm like, yeah, I could see his frustration with where like some devices, they were getting calls from the ER because the Plerex, I guess, wouldn't connect to wall suction and stuff like that. I haven't seen the other devices around. Like I've never seen Acept on the shelf anywhere or the Rocket on the shelf anywhere. I've only ever seen Plerex and Aspira, and I can't really tell you the difference between the two of them. You know, like you said, if somebody had it on the back table, it's just like, okay, looks like another, tunnel catheter. Do you guys know any big differences?
The Plerex has a proprietary hookup. I know that. And then the Aspira, I think it's just a standard lower lock. But what I will say, like whatever catheter that you decide, I think the important thing is, I mean, look, if you're starting like de novo and you want to look at all the different ones, that's fine. I mean, I think that's great. You see what resources are available to you, both from like the reps that stock them to like what price you can get. But in the end, the ER visits or like the adapters that come with all the kits, like whether you can get home health, like their familiarity with it, it's going to be like location specific. And I think you just have to work out a couple of those things, but none of the hurdles with any of the brands are insurmountable. Like, I think if you just have like a little bit of due diligence ahead of time, like all these little problem things that you're going to run into are very, very solvable, from ER visits to home supplies.
Yeah, I'll tell you the big difference I saw early on when I was learning this was, and this is going to be like location specific, is my Bard rep, this was back before BD purchased Bard when it was Pleurex, they would come in and counsel the patient, educate the patient. They would fill out all my paperwork and make sure that those patients got those supplies.
Wow.
And that was the biggest thing. That was such a huge help. And so if there's any sales reps listening right now, like that's where you can help your docs out with that kind of stuff. And if you don't have time to be there for every case, that's totally reasonable. But like train the nerd, like find one quarterback or one point person to train up so that that's taken care of, so that the doc doesn't have to worry about it. Like one hospital I go to, the doc's so stressed out about the patient getting the supplies. He's like faxing it himself. And I'm like, dude, I don't have time to like fill it out, fax it, and then follow up with the company a day later. Like nobody has time for that, right?
Yeah.
But there are people at the hospital that have time for that. There's a lot of people sitting around. So, assign somebody to do that, right? Delegate and elevate.
I don't think you're allowed to say that, Aaron.
There are at my house. The hospitals I work at, there's a lot of people sitting around and they could be doing something.
Agreed. So much of our job, and I think we've talked about this on other episodes, but like so much of our job satisfaction as doctors too is making somebody else do a lot of those administrative tasks that we get charged with that like really do not need to be our job and can easily be done by a nurse, a tech, an administrator, a registration specialist, getting that stuff off of our plate so we can just focus and be efficient at our procedures.
Yeah, exactly. That I think is a huge source of frustration for us, that we have there's more of this that we have to do. There's more charting that we have to put in our EMRs. It's gotten out of control. The other question I forgot to ask you guys, are you guys just doing moderate sedation for these patients? Lido only, general anesthesia? I mean, for me, it's just moderate sedation.
Moderate sedation for me.
Same.
Not a particularly painful procedure when considering like a lot of these patients have been stuck before. I will say though, like I do think it is important. I'm a big advocate of lidocaine. Like lidocaine is like, I hate it when like someone just like gives me the 5 ml vial and like, you have all the lidocaine you need. I'm like, that's never how much I need.
Yes, you're right.
Do not feel compelled to like be limited by the 5 ml vial that comes in whatever shitty kit someone hands to me. But I do like a lot of lidocaine and some decent sedation for these, because especially with the pleural catheters, when they start to splint and bring down that arm, or for some reason, anything that they do like that kind of like narrows that area, I feel like it can kind of pinch your catheter as it's going in. It can kind of, that's like the one hiccup that like can come up periodically, is like when you have like a really thin patient or you just don't have a good intercostal space to work with. I don't like it when the PLOA sheath gets kind of pinched. That creates like sticky point, but few and far.
What do you guys do about loculated effusions? You guys have many of these come back where they're just not draining, and then they get a CT, or you're looking at ultrasound, you see septations all over the place. What do you guys do about those?
I'd like to hear what Allie does first.
That's a really hard one. And honestly, that's probably like the number one complaint we get about it. The classic scenario is ER calls you because patient has had a Pleurex catheter and it's not working and nothing has drained for like the past week or whatever. Our algorithm for that is we just start by getting a CT scan to see if there's anything left, right? And then if there is something left, we try to flush it, right? Because it could just be clogged up. And then if that doesn't work and it doesn't start draining immediately, we'll put an ultrasound probe on it. If it looks like it's loculated, I mean, there's not really a great solution for it. Some of the thoracic surgery guys in our group will do TPA through that to clear it up, but none of the IR doctors are really proponents of that. I'd love to know if that worked. Anytime I see the surgeons do it or the medicine floor do it, it hasn't been super successful, but maybe I have bias because I just see the ones that fail, right? And then sometimes what we'll do is we'll take it out and put it in an area that doesn't look loculated, right? Or we'll talk to the patient and see how their symptoms are, because a lot of times when it's loculated, it's small enough that the patients aren't having significant symptoms from it, right? And so then you're like, well, the whole point of this is for symptoms, right? It's not just to make your pleural space drained. And maybe loculation is the first step towards pleurodesis. So I don't have a great solution for when it's loculated, just to come back to your question. Do you guys have one?
Actually, I thought your algorithm was like perfect. And like you said, the thing that's the key question is the patient still symptomatic? And like the scenario that you're describing, you put it in, it's like a big effusion. It's been tapped before, it's free flowing, but all of a sudden, for whatever reason, now it comes back loculated. The patient comes to the ER and, they've been getting a liter off religiously for 1 week, and all of a sudden it's not, and that's an issue. But it's like, well, how symptomatic are you? Like, are we meeting your treatment goals? And that is like the absolute key question. And then like to echo Allie's point, like what you do there, You get the CT scan, put an ultrasound probe on it. You want to see if there's residual fluid. Is it truly loculated? How complex it is? And sometimes at that point, I'd like to start from the position, even though there's a pleural catheter in there, and so you do have some options. I do like TPA, a TPA installation. I say that I like it, only that's what I recommend, but I'm not the one who has to deal with it. The pulmonologists do, and actually sometimes you can salvage catheters, or you end up in a big pocket and you're clearing away that pocket. Sometimes the decision's just to pull the catheter, and you just have to manage it differently than the effusion that you started with.
Can you walk me through, Chris, how you do the TPA installation? Because maybe that's where we differ on that.
Yeah, to give us your cocktail so that maybe we can try something more successful.
I don't want to pretend like I have the cocktail. I just say, hey, you guys need to try a TPA installation.
Oh.
But if I did, I've done TPA for other things. If I had to think, I'd probably do 10. And I'm scared to if people are going to start trying this on their floor patients. But I think systemic TPA and then TPA into a cavity are very different things, and I treat them differently. Now, nursing may not do that. So, you may have to escalate the level of care, because the last thing you want to do is be the guy up there futzing around doing the TPA installation. This is a medication administration and a safe practice, but I'd probably do 10 milligrams of TPA and a quarter or half a liter of fluid, and still it for 30 to 60 minutes, and then try and pull it out afterwards. And you document how much goes in, how much comes out. And so actually I have to walk that back. Half a liter of fluid seems way too much, but 200 to 250 cc's, I'd want a good volume of Installate or saline with about 10 milligrams of TPA, and then see what you get out at the end.
Yeah, see, that's what makes me nervous is is a nurse going to give it IV, or is she going to actually, you know what I mean? So I would go and do it myself.
Yeah, okay. I mean, look, I'm not, there's always this scenario, if Aaron Fritz does it, is it going to be safer and better than maybe the RN on the floor? Probably, but Aaron Fritz's time is very finite. Sometimes you just have to put your orders in, make it clear.
Yeah, tech is handy because tech can't give an IV medication. Allie, when the TPA doesn't work and that's been tried and there's clearly septations, is I will actually, if the vector's just right, I'll take a wire, an Amplatz wire, and run it through there and see if I can break up some of the septations with the Amplatz. And, if that doesn't work, then I have that conversation with them hey, this isn't working. It's not going to work, right? So let's pull it out. And if you want another catheter in, maybe we could do a pigtail in the biggest pocket just for relief and go from there, because that's if they're going to stay inpatient. Now, clearly you can't send them home like that. Do you guys ever send them home with a pigtail without, we do in other cavities, right? But I guess it's a little bit more problematic when it's in the chest.
Yeah, you have a Pleurovac container. I'm really, really reluctant to do it, but have with a couple of patients that hospice swears up and down to me that they're not going to make it past the week. And so is it my favorite thing to do? No, but when you look at a patient that's terminally ill, and it's the difference between trying to sort out this very difficult, complex pleural effusion that, sometimes it just takes time, versus putting a pigtail, cut the Gordian knot, get them home. I'm all about it. Go ahead, put it in, and then wish them their best. I think, again, it goes back to the difficulty in talking about different patient populations, and then in a regular effusion versus a loculated effusion. What I will say is, though, if you do have a pretty loculated effusion, it can vary from patient to patient, but I think you want to look at other things to sort out, because there's a lot of different ways. We haven't even talked about pleurodesis or getting to the underlying etiology of treating the effusions. This is not the all end all cure for pleural effusions. And sometimes with loculated effusions, I feel it's trying to put a square peg in a round hole, that sometimes it's just not a good fit for patients.
All right, I think that does it. Thank you guys so much.
All right, thanks, Aaron.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_backtable on Instagram, Twitter, or LinkedIn. Backtable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Don, Michael Barraza,
and Allie Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson
and Delaney Aguilar.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon.
Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.